Hi, everyone, and welcome to the Voice of Pancreatic Cancer podcast. I'm Miranda Weinberg with the Sina Magowitz Foundation. And if you don't know about the Sina Magowitz Foundation, we're a nonprofit that's committed to the awareness, prevention, and cure of pancreatic cancer. One of the ways that we do that is through partnerships with organizations like the Medical College of Wisconsin, who also share that same value. So today we're going to be talking with Dr. Susan Tsai and Jenny Geurts. And now I'm going to read you Jenny's title because it's quite a lengthy one. She's the director of the Master of Science in Genetic Counseling Program in the Institute for Health and Equity, and also the Associate Director of Genetic Counseling at the Genomic Science and Precision Medicine Center. So thank you both for being here.
Thanks for having us, Miranda.
And I'm excited.
Thank you, Miranda.
Yeah, good to see you. And if you guys have been tuning in, you probably recognize Dr. Tsai. She's been with us before. So today we're going to be talking about genetic testing. But before we begin, I'd like to just take a moment to thank our sponsors. We wouldn't be able to impact the lives that we are able to reach without you guys. So let's go ahead and dive in. I mean, I think it would be good for those of us that are unfamiliar to talk about what a genetic counselor actually does. And Jenny, I think it would be interesting to know how you got involved in this.
Wonderful. Thanks, Miranda. Yeah, so a genetic counselor is another member of the care team for those that have been familiar with getting treatment for pancreatic cancer, maybe attended appointments for a loved one. They'll know there's many people on the care team. So folks like Dr. Tsai, who's a surgeon that specializes in pancreatic cancer, medical oncologists, nurse practitioners, dietitians, diabetes educators, the list goes on and on. So I'm proud to be one of those multidisciplinary team members in genetic counseling. So when I explain it to patients, I explain that coming to see us is like having a big pie, and I'm just a little slice of the pie. So I'm the genetic slice. So for genetics, what we're doing for patients is we're trying to answer the question of why did this happen? Which is often a huge question, and it's not easy to answer, and we can't always provide answers. And then we're also trying to answer the question of, what does this mean for my family? Are they at risk? Is this something that they could also develop? And then more recently, we've been involved in asking the question and answering the question of, is there a way that my cancer could be treated more effectively through precision medicine and genetics? So those are the three main areas that we touch on, of course, with our clinical partners in practice. And as a genetic counselor myself, just a little bit about my training, if that's helpful for your audience to know. I have my Master of Science degree in genetic counseling. That's my terminal degree. And I attend a training program that lasts 2 years. So a lot of courses about genetics and knowledge about genetics, and then clinical practicum. So I go into clinics and I got experience in training in all different sorts of genetic syndromes and, prenatal, pediatrics, cancer, cardiology. There's all different ways that genetics are affecting diseases. And then after that, I take a board exam. So I get certified in my field. So I'm a board certified genetic counselor. And that's what brings us to present day. I will say my interest in cancer was longstanding. And prior to being at the medical college, I've been here for about 10 years. I had always been interested in pancreatic cancer. I just had been drawn to this disease that, even 10 years ago, we've come a long way. We have much more ways to go, but I wanted to make an impact. And when I looked at the different cancers, it seemed that pancreatic cancer had the most opportunity and maybe wasn't getting as much attention as some of the other cancers were when it came to genetics. So I thought, here's a real chance to explore what genetics could mean for these patients.
Okay. And then I'm curious, what drew you to genetics specifically for, studying?
Yeah. Okay. I'm one of those kids that from very early on, I think I was in 8th grade, I can distinctly remember learning about the Punnett square. Do you remember the Gregor Mendel and the green peas and the wrinkly peas? And they taught them, and I remember thinking like, this is amazing. And I looked around my very small classroom. I think I just had 20 kids in my class, and everybody was either like sleeping or extremely bored or irritated and not interested. And I thought, what's wrong with me that I'm the only one that finds green wrinkly peas interesting? So I thought that probably would make sense for me to explore a career in genetics. And I was fortunate enough early on to come across genetic counseling as a career, which was an emerging field at the time. And I fell in love with it from day one.
Awesome. Well, thank you so much for that explanation. I think it would be good as well, before we dive too deep into, explain a little bit of the terminology. So, genetic counseling versus genetic testing.
Yes, thank you. This is an important distinction, Miranda, because I think a lot of times folks may have some hesitancies about genetic counseling and genetic testing, which is completely understood. I think folks don't necessarily know what's going to be involved with genetic testing. And the point of the genetic counseling is an office visit, is a time to sit down, get those questions answered. Seeing a genetic counselor doesn't mean that the person is guaranteed to get a genetic test or has to get a genetic test. It's really to sit down and have that conversation about, what would this test mean for you? How might it impact your care? How might it impact your family? Does this test have medical utility for you? Does it have personal utility? Those two things may be different. And just understanding kind of the ramifications so that we can truly make an informed decision. I think patients that maybe have been hesitant to do genetic testing, I would say it's fine if somebody doesn't want the genetic test, as long as it's an informed decision. Not a decision based out of fear. So that's what we try to do, is we try to meet patients where they're at, provide education to help them understand what the testing means, what it can do and what it can't do. It's not a crystal ball. And then just help them come to the right decision for them.
Okay. And Dr. Tsai, I want to turn it to you now to talk about the different types of genetic testing.
Yeah. So, Jenny, I feel like when you turn on the TV these days, you hear all of these commercials about genetic testing. And can you just maybe explain like how the genetic testing that you might offer is different from like 23andMe, and maybe just give some insights into how things are different in terms of the test and maybe even what's tested?
Absolutely. So I like to compare the genome, that's all of our DNA and every cell in our body, to like a big set of encyclopedias, for those of you who are old enough to remember using encyclopedias. Okay, so it's a huge set of encyclopedias. And so when we do genetic testing, we're reading those encyclopedias, we're reading the information to try to understand, what we call the blueprint of life, right? What these genes are that are programmed to tell our body how to grow, how to develop, how our heart should beat, all of that. So DNA testing is reading those genes, reading that encyclopedia, that book, that instruction manual. And you're right, Susan, there's lots of different types of genetic tests, and it's important to be informed of why, a test that they might order online through a direct-to-consumer company is a lot different than the test you're going to get from your doctor's office and with a genetic counselor. So the tests with a genetic counselor are more comprehensive and targeted and have specific medical indications. So when we see some of the advertisements for what I call recreational DNA testing, the things like 23andMe or Ancestry.com, it's just that, it's for fun, right? It's to know, where did your ancestors come from, or some of the traits. There's one test where you can see, like, are my earlobes detached or attached? And,
it's like something you could probably tell that in a mirror, right?
That's exactly it, Susan. I call it the mirror test. Right. Like, do I have red hair or not? Well, look in the mirror. You should know. But it's kind of fun, and there are some silly things in there too, that they have, which is kind of more personality traits. And then some of the testing, that recreational testing, starts to bleed over to this gray area where you could imagine there might be some clinical relevance. So for example, with the cancer genes, 23andMe, one of the companies that offers testing, does look at what they call the breast cancer genes. Now, what they do is they look at 3 spots in the breast cancer genes that are more common in folks of Jewish ancestry, specifically Ashkenazi Jewish heritage, because we know that they're more likely to carry these particular genetic changes. Now, the issue is, if you were an uninformed consumer and thought, oh my gosh, this is great, this test, it's, $200, I can spit in a tube and then they'll tell me if I'm going to get breast cancer. That's not what it does. It's only looking to see if you have those 3 particular markers. And there are literally thousands of different markers that can be evaluated. And so when we do the test in clinic, what we're doing is we're looking and we're sequencing, meaning reading that entire gene and all of the genes associated with hereditary breast cancer to see if there's any variation anywhere in those genes that could lead to cancer. So that's a big difference than those recreational tests where they're just looking at 3 spots on the gene. It's not as comprehensive of a focus as ours is.
So Jenny, just to recap, so when they do that kind of testing, it's like the Cliff Notes version, right? Like you're just getting the highlights, but you may not actually understand the substance at all of what was going on. So you can miss something.
Exactly. Yeah. Going back to that encyclopedia example, it's like if you just opened a random page in the encyclopedia and just stuck your finger on a word, you wouldn't have the context of what that all means without reading the entire book.
Great. That's a great analogy. And then maybe can you tell, I think it's a little bit confusing sometimes when we talk about germline versus somatic. And I think a lot of people say, oh, this, personalized medicine, precision medicine, I'm going to get my tumor tested. How is that different or the same from like germline or genetic, more hereditary testing, I guess?
Yeah. So just to clarify the terms. So exactly right. So germline testing, or what we call hereditary testing, is testing the DNA that you were essentially born with, the DNA that you got from your mother and father. And so when we're evaluating that DNA, we're looking to see if there were any genetic changes that you had inherited from birth that might predispose you to cancer. Okay. Because when that happens, like the example with BRCA, it's not that the gene is passed on and the child is born with cancer. No, and it's not even a guarantee that they would get cancer. It's that there's a genetic variation there that predisposes to cancer happening. So it might happen. And different genes are associated with different levels of risk. So we can kind of quantify that. So that test is typically, again, a saliva sample because the DNA that's in your mouth is the same as the DNA all over your body. It's the DNA you were born with. Or we can get a blood sample. That's a nice other easy way to get DNA. But technically, you could get DNA anywhere from your body that would be considered a germline sample representative of the DNA you were born with. And that's to evaluate for a hereditary predisposition. Now, that has differences and similarities to what you're speaking of, Susan, the somatic testing or tumor testing that you'll see that has really exploded in the last 5 to 10 years and has really offered some amazing promise for the precision treatment of cancer. And what they're doing there is, for the most part, is typically getting a biopsy of the tumor itself. So in the example of pancreatic cancer, ideally, they're trying to get a piece of that tumor from the pancreas, and they're evaluating what genetic changes occurred just in the pancreas that caused the cancer. So not genetic changes that you were born with necessarily, but the genetic changes that just happened in that tissue in the pancreas. The word is somatic. That's the medical word for it. So that somatic testing tells us what types of medications might be most effective against those particular genetic changes found in the tumor. And where it can get a little bit confusing is if you imagine you were born with, for example, a BRCA2 gene mutation, and BRCA2 is one of the genes that was originally discovered in families with breast cancer. But then we realized, oh, this is also related to ovarian cancer and also related to pancreatic cancer and other cancers. That gene, BRCA2, if you were born with a genetic mutation, it would be present in your saliva cells, it would be present in your blood cells, and it would be present in your pancreas. And if over time, additional genetic mutations were acquired in your pancreas, sometimes we can identify things that cause that, things like cigarette smoking or heavy alcohol use. Most of the time, it's just random. It's just chance. And so those additional mutations that might occur over a patient's lifetime in the pancreas, on top of that BRCA2 mutation they were born with, leads to cancer. And so when we do that somatic testing in the tumor, sometimes we can incidentally pick up that, oh, also it looks like there's also a germline mutation. One of these mutations that we found in the pancreas the patient was born with, the rest of those were acquired later. So it gets a little tricky. It's even tricky for clinicians, to be perfectly honest with you. I don't expect patients to always be able to sort it out, but it's important to know when we ask, have you had genetic testing? Has your family member had genetic testing? We want to understand what type of testing they had. Was the tumor tested to determine what treatment's most effective? Or was the patient's germline or that genetic test that's usually a blood sample or a saliva sample, was that tested to determine if there was an inherited cancer gene mutation?
So when people refer to tumor testing, that is somatic testing. Those are one and the same.
Yeah.
Okay.
Yeah, you got it, Miranda. See how easy it is?
Slowly but surely, we'll figure this out. For genetic testing, for when someone hears that and they think about the 23andMe versus getting this deeper test, would you encourage everyone to do it? I mean, how does a patient know that they qualify?
Oh, yeah, that's a wonderful question, Miranda. I think, really that's the question, is who gets genetic testing? Who even has access to genetic testing? There are some folks out there who advocate that this should be population health, that just anybody who wants it should get it. And I think they have good arguments and some good data. I think, of course, we have to keep in mind is how informed are people when they're pursuing this, and what does a positive result mean? It's not destiny. As I mentioned, it's not a crystal ball. It doesn't guarantee someone's going to get cancer. So we want to make sure that they kind of emotionally and mentally manage that information. Okay. But reality is right now, we have criteria. Criteria can be set by professional guidelines, evidence-based, consensus, expert consensus, and based on the medical literature. And then we have guidelines that are insurance-based. So those can unfortunately differ sometimes. So I will tell you that right now, professional societies, but very well respected societies, and many insurance companies say that anyone who has had pancreatic adenocarcinoma, that's the more common type of pancreatic cancer, should be offered genetic testing to evaluate for those germline mutations to see if it was an inherited cause to their cancer. So that's something that many insurances are covering. Mm-hmm. And because the technology is getting so much better, even if the patient maybe qualifies based on professional guidelines or their doctor's recommendation, but they don't have insurance coverage, many of the labs that we work with are able to provide, support or reduce cost. So that nowadays, most patients, even if they didn't have any insurance coverage, it might just be a couple $100s out of pocket. When the technology first came out decades ago, it was thousands of dollars. But because the technology has gotten so much better, much like, plasma TVs, I remember, we got the first big screen TV was like $4,000, right? Now you can go to Costco and pick up a big screen TV for like $700. So it's kind of similar idea with the genetic testing is it's really come down. We've been able to increase the quality. We've been able to look at more genes and understand the variation in those genes better. And we've been able to do it at a more affordable price, which has helped with insurance coverage, but also helped for patients who may not have that insurance coverage to reduce that out-of-pocket expense to them. And that's something that the genetic counselor helps with. So that's part of, why would someone consider having a genetic counseling appointment? It's just to navigate that kind of access and affordability of the test. It's not a guarantee that they would have to have the test if they come see us. It's a conversation about what do you want to do? What would your insurance cover? What would be any out of pocket? So that they can, again, make that informed decision.
Okay. And then you talked about insurance coverage for the patient. What does that ever extend to the patient's families? I mean, maybe a family member that is concerned now that they found out this is in there.
Typically, the way I will say the U.S. healthcare system works is that if it was so let's say an individual was tested and they found out they had a genetic mutation that predisposed to pancreatic cancer, and their daughter wanted to find out. And so again, now typically with these genes, they don't affect children. It's not causing childhood onset cancers typically. So for most of these genes, we're not offering children testing because it doesn't medically impact them at that age. So we wait till they're adults. So we usually wait till they're 18 or just emotionally kind of ready to take on this information. But let's say their adult age child wanted to have the testing. We would then go under that person's insurance, that individual, so the child's insurance. So if there was an adult age child, let's say 25 years old, has their job and their insurance through their job, we would then apply through that person's insurance. Very rarely do insurance companies cover individuals that are not on the insured plan.
Right. But just having a family member and having that family history, the insurance would take that into account.
Absolutely. And that's a lot of times for family members who want the testing, we go through their own insurance. But once we explain to the insurance company, there's already a known gene mutation in the family, we know this is happening, it's pretty much an automatic.
Okay. And then you mentioned that even if the insurance doesn't cover it, nowadays it's more affordable than it would have been back 10 years ago to do an out-of-pocket cost.
Absolutely. We never want cost to be the barrier for the patient. I think there's many reasons patients may not want to pursue genetic testing, but cost, if that is the one reason, we want to be able to work with them and work with the laboratories to make sure that we can get those expenses covered. So that's not a concern.
Okay. And then is there, this might be a question that kind of varies, but is there a range of out-of-pocket costs that you could say it's going to cost anywhere between this and this?
I would say most of our patients, it's, under $10. But it kind of ranges up to maybe like $250 or $300.
Oh, awesome.
Jenny, can I just ask you to clarify, just because as I was listening, I realized it might be a little bit confusing. So when you said genetic testing for patients who have a diagnosis of pancreas cancer is recommended, I think that's like pretty straightforward. But what about for people who don't have pancreas cancer, but have like maybe they're worried about their family, maybe they heard someone had pancreas cancer. So what, in terms of like insurance coverage or criteria, what criteria for someone who does not have pancreas cancer should they be considering germline testing or?
Yes, absolutely. So what we do, as part of the genetic counseling appointment, typically one of the first things we do is collect that family history. So we're going to ask not only who in the family's had pancreatic cancer, but any type of cancer. Because unfortunately, many of these cancers are related. I mentioned, breast and ovarian related to pancreas, and there's others like colon and endometrial that can be related. So we want to make sure that we're looking for any type of cancer. Melanoma is another good example. And based on that assessment of the family history is then, and if the patient decides that they want to pursue testing, we'll do that authorization with their insurance to make sure that they meet the criteria, because they will do what's called family history-based criteria, even if the patient themselves doesn't have cancer, as long as there's something in the family history that indicates this is a high risk or that it's warranted, then yes. And in each insurance company, those criteria look a little bit different, but for the most part, we're able to be successful. And in the worst case scenarios, we might need to write a letter of medical necessity describing to the insurance company why we're doing this and someone who doesn't have cancer. And we explain, because we're trying to help them not get cancer. And usually that's a pretty effective argument.
So I have a question. If it doesn't run in the family, or you haven't seen any family history of it, is there any positive reason to get the genetic testing?
Yeah, so this is the tricky thing, Miranda. I think, originally when the BRCA genes were discovered, as I mentioned, they were discovered in families with breast cancer. And then after we studied them longer, we realized, there's other cancers to pay attention to. And I think that's what we're finding is we're finding families, and I know, I'm sure Susan's been surprised by some of our results as well, where even though there's not a strong family history, you may not see every generation affected. You may not see young individuals with cancer. You might just see one individual with cancer. It can still be hereditary. We can still do the genetic test and discover that actually, in fact, you do carry this mutation. And that's why the guidelines have changed that any individual with pancreatic cancer, regardless of their family history, should be offered the testing. And again, like I said, if you have a family history, you can usually meet those criteria as well. But that's the thing, is we haven't necessarily done a great job at predicting who will have that inherited mutation and who won't. Mm-hmm. There are some families where I'm just really surprised, because it's like, well, you were the only one in the family. How, there wasn't a history of it. But, I have to say, family history it's an oral story that's passed down through generations, and it's inherently flawed. So it's not an official, court document. It's something that, I heard from grandma so-and-so. And especially with some cancers like melanoma, some people may not even really report that. Or they may incorrectly report it. They may report it as just kind of more of a benign skin cancer, when we treat melanoma a little bit differently. Or they may misreport, sometimes you may have heard, if you ever talk to older family members, they may say, well, Aunt Sally, she went into the doctor and she went on the operating table and she never came home. And that's all like operating table for what? What happened? Was there a cancer there? So I think that's part of the challenge, is some families, they didn't have real accurate information about the diagnoses. Or also, in addition, sometimes it wasn't just family culture. It wasn't appropriate to talk about that, right?
Right.
It wasn't that long ago when people referred to cancer as the C word, and didn't share with that information with family because they didn't want to upset them. I think now generations are understanding, actually, no, this information empowers us to take action and can help prevent or detect cancer early. And that's the focus that we want to look for moving forward. But generations ago, that wasn't always the case. And so if we're relying on that old information, where records maybe weren't kept, where family lore was passed down, we just don't know.
Okay. Hey, can I just follow up on that too? So for our listeners who might be at home and just thinking about their own families, and they maybe have like an uncle who has pancreas cancer, aside from that, if they don't know anything else kind of suspicious, should those people get tested, or what is like a family history that should be concerning for pancreas cancer?
Well, there's a couple things that we look at. One I mentioned was ancestry. Unfortunately, these mutations are more common in folks of Jewish ancestry. So about 1 in 40 folks of Ashkenazi Jewish ancestry are carriers for one of these gene mutations. So if it's just you had one uncle and that's it, but yet you have Jewish ancestry, I'd still say that needs to be investigated. I think a lot of things that we look at when we do that, what we call pedigree analysis, meaning really looking at the family history, we're looking at how big is the family. So, okay, one uncle had pancreatic cancer, but was it a big farm family and you had 10 aunts and uncles on that side and everyone lived into their 90s and nobody ever got cancer? I'd be more reassured by that. Or is that your only uncle, on that side of the family? So this is an important distinction.
So regarding these tests, is there any truth to the concept of ignorance is bliss? Is it really better to know if you have one of these mutations?
So a little of that is kind of in the eye of the beholder and your personality, and kind of, if you're the type that is empowered by information or not. And I would say, it's important to make a distinction between pancreatic cancer and maybe conditions like Alzheimer's disease, where if you find out you're at risk for developing Alzheimer's disease, medically, can your doctors do anything different for you? It's hard to say right now how medically useful that information is, maybe personally useful to you. With pancreatic cancer, there's more hope on the horizon. There's been some wonderful things happening with pancreatic cancer screening. And I think that's one of the questions that I would have a patient ask themselves is, how would you use this information? Because we can detect pancreatic cancer early when we know who to screen. So, the first step is looking at that family history and saying, okay, is this a family history that would qualify to consider genetic testing? The second step is to offer the genetic testing for family members that want to know that information. And in some families, we're able to identify that genetic mutation. Like I mentioned, BRCA2 is one of those examples, but there's other genes. And we're able to have a really informative genetic marker that says, either you have the gene or you don't. And so we can divide the family into two different groups and say, these family members do not have the gene that's been causing the pancreatic cancer in the family. And these family members that didn't inherit that gene are at average risk and can be reassured. We still are at risk for, population risk for cancer, because everyone's at risk for developing cancer, but they're at least not high risk for pancreatic cancer. And then the other group in the family who did identify as testing positive for the genetic mutation, it's not a guarantee that the cancer will happen. We know it's an increased risk, and it depends on the gene. An increased risk anywhere from, 2 or 3% lifetime risk for pancreatic cancer, maybe upwards to some of the stronger genes, like a 30 to 40% chance for pancreatic cancer. So somewhere in that range. So by no means 100%. But that would be their lifetime risk. And we don't want them just sitting and stewing with that information. We want them to feel empowered and do something about it. So for those individuals who would test positive for the gene in the family, we would offer them pancreatic cancer screening. And so we offer that screening every year. And at our center at the medical college, Dr. Tsai runs an amazing pancreatic cancer screening program for several years now, where we've been following folks with an MRI of the pancreas every year. And they get a nice, really crystal clear, detailed image of that pancreas. So if a cancer is going to crop up, we want to find it as soon as possible. When it's a little, I call it a ditzel on the MRI. When it's just a little ditzel, and we can say, wait a minute, something's there that needs to be taken a look at. Rather than, unfortunately, what happens for the majority of cases, as your listeners may know, is waiting for those symptoms to arise. And by that time that we're starting to see things like jaundice and the abdominal pain and the GI issues, and unfortunately, in many cases, it's pretty advanced. So the best chance at beating it is if we can find it early before symptoms ever arise. And for us, we feel that MRI, offers that. And we've got some pretty good patients that we're following to do just that, to offer them hope in that if it is going to happen, we'll be there to find it early and treat it right away.
Jenny, can you kind of follow up on that? So who would you think should benefit from screening for pancreatic cancer? Is that like everybody, or what are your criteria?
Yeah, so criteria is very personalized. So we talked about the gene. So that's kind of one group that's pretty clear. When they meet with me, we go through what are the genetic results and, who in the family has had the genetic testing, and what does this genetic test mean for their pancreatic cancer risk? The family.
Before you go on, can I just ask you? Can you just maybe for the listeners give examples of the more common genes? Because I think sometimes people maybe, if they're not associated with a high volume center, they may not know that they may have this gene, and now they should actually also be screened for pancreas cancer.
That's a good point, because certainly this information has evolved over time. And what the doctors and care teams were doing, 10, 15 years ago is much different than what we're doing today. So I think that's important to highlight, is that patients and families may even been told information that's much different than what we would say today. So I know firsthand that patients, 20 years ago were told if they had a family member with pancreatic cancer, oh, it's not hereditary, don't worry about it, because we didn't understand at that time. And now we understand that, maybe upwards of 10, even 15% in some cases of pancreatic cancer are in fact hereditary. So that family may be still going off of that outdated information, rather than, kind of getting the new information they would need to hear from their doctors. So for the genetic syndrome, so like I said, if we can offer genetic testing to anyone in the family where there's pancreatic cancer and we're concerned for that hereditary risk, and we identify any of those gene mutations in different conditions, like I mentioned, BRCA1 and 2, another condition associated with colon cancer and endometrial cancer called Lynch syndrome. There's another syndrome that's related more to melanoma. So these are the types of things that we're looking for. And we identify a gene, then we have that genetic marker. But where it really becomes challenging is that for those who have the genetic test and we didn't find anything. So let's say, and we have this family, I think about them all the time. There's 5 family members with pancreatic cancer. And I tested the grandmother who had pancreatic cancer with the best technology I had to offer at the time, and we couldn't find the gene mutation that was causing the pancreatic cancer. Now, I'm not going to tell that family, oh, don't worry about it. We did the genetic test. It was normal, because I know something's going on. You don't just get 5 family members with pancreatic cancer by chance. And I say to them, our technology just isn't good enough to detect those mutations right now. And there's probably something there that we'll be able to find in time, but right now we don't have a good answer. And so we label families as familial pancreatic cancer when we haven't been able to pinpoint a specific single gene mutation running in that family, but we still think, based on the clustering of family members, that they are deserving and it warrants pancreatic cancer screening, because something must be going on. So an example of that would be, if an individual, there's no gene mutation that they know of in the family, but they have 2 first-degree relatives. So like a mother and a brother. Your first-degree relatives are your parents, your siblings, and your children. So having 2 first-degree relatives would warrant pancreatic cancer screening.
Okay.
Can I ask one other thing too, Jenny? So besides for pancreas cancer, like a family history of pancreatitis, what are your thoughts about that?
Yeah, so pancreatitis is complicated because it can be due to various causes, and there's different genes that we look at for that. So if a family member has kind of what we maybe call idiopathic pancreatitis, meaning we don't know why it happens, it's not because of alcoholism or some known cause like an anatomy issue, but it just, they're getting this recurrent pancreatitis, and the pancreas is very inflamed and irritated, and it's like a chronic issue. We offer them genetic testing for a different set of genes, because that can also run in families, and then those are also patients that we want to be able to screen through our high-risk protocol as well.
Okay, so on screening, and we've talked a lot about testing, let's talk about, once you've done the testing and you get the results, how do patients interpret these results? I mean, what are some buzzwords they should be looking out for?
Yeah, so I think genetics can be a little tricky sometimes, because sometimes we find variation in the genes that we haven't seen before, and we don't quite know what to expect. So I will say it's not uncommon that when we do a big genetic test, and these are what we call gene panels. So we're looking at multiple different types of genes that are all related to hereditary cancer. It's like reading multiple books of that encyclopedia set, okay? Sometimes we come across a variation in a gene that we just don't know what it means. So we're learning a lot more about the human genome. It's been, we know the letters and what they should say, but we also recognize there's a lot of variation in populations that can just be ancestral based. And so we have a lot more work that we need to do to gather more understanding of what variation means in folks of different ancestral groups, so that we can truly see what is a normal variation and what is a variation that could actually cause disease. So the buzzword that some patients might hear is a variant of uncertain significance, or a VUS.
Okay.
That one's not fun for us. It basically means they read the DNA and they found this variation that, they either hadn't seen before or hadn't seen very commonly, and they don't know how to interpret it. And so we have to treat it as normal, because we just don't know. We can't assume it causes disease. And most of these variations do end up being normal, but we keep it on our radar. I'll put it that way. So that as the laboratory gathers more data, just as more research is done in the medical community, and we understand more about variation in different populations, the lab will come back and say, okay, well, that variant is really benign. It's normal. It doesn't cause disease. That's what happens over 95% of the time. When we get one of those VUSs, it's reclassified as normal. But in a small percentage of the time, they find that VUS and they get more data that determines it actually could cause disease. So then we have to, call the patient back and we say, okay, remember that test you had 5 years ago where you had that inconclusive results, that VUS? There's some new data that tells us that this may actually lead to cancer. So we need to start screening now, or we need to start taking action now, whatever that action may be.
Okay. And Jenny, just to follow up on that, I think as you alluded to before, like the genetic testing, and it's just evolving so quickly. I think one of the questions in terms of not only classification of like a VUS as causing disease or not causing disease, but even like knowing when people might need to just get retested, that the panel is now expanded so much, so what is your kind of, thought about that? Is it like maybe in 5 years or 10 years, or once they're tested, can you just say, yeah, it's fine. They didn't find anything. I'm okay.
Yeah, no, certainly. That's the interesting thing about genetics. If you would have told me, 10 years ago that we'd be where we are today, I would have said, I don't believe you. It's because it's exponential growth. The knowledge grows exponentially. And so we typically tell patients, just check in with us annually, even if it's just a quick MyChart message, like, hey, anything new? Because then we can review their family history, review their results, and say, oh, nope, we're still doing the same testing. Nothing's changed. Or, actually there is a new gene that's been discovered, or there's new technology that's out, emerging technology about like RNA analysis, for example. And we want to be able to offer those families an updated test, particularly those strong families, like the one I described where there was 5 family members with pancreatic cancer. It's like the answer just feels so close, but so far away. And so we really want those families to stay in touch and follow up with us regularly. It wouldn't be unreasonable to, get retested maybe on a 5-year interval or something like that, but at least check in annually.
Okay. And you would recommend that the patients take charge of getting those status updates versus, waiting to be contacted when new information comes in?
Yeah, I think with the way that medical records work, and unfortunately, a lot of times that responsibility kind of does fall back on the patient to follow up with their provider. Unless they are regularly scheduling the appointment, it's hard with databases and things to really identify individual patients and reach out and contact them individually when updates happen.
Okay. All right. Awesome. Dr. Tsai, is there anything that you think we missed question-wise? Jenny?
No, I think that was great. I mean, I feel like I always learn so much when I hear Jenny talk about genetics. So this has been a real treat for me.
Thanks, Susan.
Yeah, it's definitely a very deep topic. So I'm really glad that you were able to explain things and really just make it a little bit more digestible for myself and for those people at home that don't know as much about genetic testing. So thank you so much for your time. And is there anything else we wanted to add?
Well, Miranda, I just want to thank you for the invitation. I think, again, any opportunity that we have to make genetic information sound, more approachable and less scary, and maybe get people to start thinking about things a little bit differently. It's becoming so routine, so standard of care. I would just encourage people, if they have questions, they have concerns, even if they're not sure that they want to have genetic testing, that's okay. Just request to meet with a genetic counselor and we can provide more information. And again, going back to that, if you feel like knowledge is power and you're the type of person who wants to kind of take things into your own hands and say, hey, if there's something I can do to prevent what's been happening in my family or find cancer early and have a better outcome, I want to do that. Then the genetic counseling is probably going to be right for you, because we'll be able to provide information that will hopefully, make you feel like you are ready to be in charge of your own healthcare and stop cancer in its tracks, really.
Yeah, at least definitely find it earlier.
Yes.
Yeah. Well, thank you, ladies, so much for joining us, and we hope to have you back again soon.
Thanks, Miranda. Have a great day.
Thanks, Miranda.